markunčaši webtui saudas Arapeni armachar الزمما يساقو كذا فولينكا مخزنة شمس ودرد الغيب بس عشان مكي تبدي شم لقب تشم خلف دوا passes
Anna, Vračar, and Matthew Reed, welcome to Reimagining Soviet Georgia. We're so glad you guys are here with us today. Anna, why don't you introduce yourself? Who are you and what do you do?
Hi, Brian. So my name is Anna. I'm based in Zagreb in Croatia. I'm an activist with the People's Health Movement Europe, but also with a couple of local groups, including the Organization for Workers' Initiative and Democratization. And in this local group, I work with a couple of comrades. We research healthcare, especially nurses organizing and the commercialization of healthcare in Croatia, which has been going on since the late 80s onwards, so especially focusing on the transition period.
And Matthew?
Yeah, hi, Brian, Sopo, and Anna. I'm Matthew. I work at the Internationale Forschungsstelle DDR, that is International Research Center, GDR. And we are sort of re-examining socialism from the 20th century. Obviously, our main focus is on the GDR, the German Democratic Republic, or East Germany, as it is commonly known. And we're sort of trying to draw out lessons for the future, particularly for progressive movements, so that we can learn from our own history and sort of reclaim this history for ourselves as well.
Great. So on today's discussion, we were going to talk about the experiences of healthcare in Socialist Yugoslavia and in the GDR. So Anna, why don't you start? Why don't you just give us a little outline of some of your research and some of your thoughts?
Yeah, sure. So maybe I can start with why we started researching healthcare in the first place here. And that was because there was essentially no left take on healthcare since we, essentially until I think 2015, when we started working on that, which was interesting because it's always such a big deal, we were always hearing about the changes that were happening. There were dozens of reforms happening in healthcare of Croatia, as well as in other countries formerly in Yugoslavia. But there was no comprehensive approach to an analysis on why this was happening and in what direction it was going. And then there was another essentially reason for us to do that, and that was because we were seeing especially primary healthcare being reimagined in a way that was pulling it away from the people and reshaping it completely compared to what we were told primary healthcare is. And when we started researching it, it was quite interesting because we saw that, when we talk about primary healthcare in the context of Europe, and maybe in BHM Europe, we do that a lot. We talk about 78 and Alma-Ata and the declaration of Alma-Ata, which kind of brings forward this vision of comprehensive primary healthcare. And what we were thinking is, well, essentially we had that even before. So if you look even at the World War II period in Yugoslavia, you see this trend of social medicine, socialized medicine, which tries to address all these social determinants of health, which are one of the core elements of the Alma-Ata Declaration. And so that was interesting for us, to see how in Yugoslavia you had something that's considered avant-garde in the mainstream in Europe and in the world in the late 70s. And it's essentially being implemented here even before. So that's how we started. And then we started digging a bit around in the archives. We were also, as much as possible, trying to talk to people who had essentially taken part in the building of this primary healthcare system, which was there before. And so that was interesting because it was, well, essentially from what we heard and what we read, it was essentially everything that primary healthcare system should look like if Alma-Ata was to be followed. So it was people-oriented, it was based in the community, it was rooted in what the community wanted and how it wanted to, you know, how it wanted healthcare to function. It was also organized in a way which was accessible not only physically but also in a number of ways. So it's throughout the Yugoslav period, you could see that healthcare centers were built in the neighborhoods, but they were also located inside or nearby factories. So it was, and I think that's something that Matthew might touch upon later on. It's very similar. So it's just reaching out to people where in the places where they live, where they spend a lot of time, and shaping this kind of healthcare to address the needs that they essentially have. So that's like the broad perspective that we took. Then there were a couple of elements which came out of here, which became more interesting for further research. One of them was definitely the way that people were encouraged or enabled to participate in healthcare and in shaping healthcare policies at a local or at a factory level, especially in the late 70s, when we have this approach to self-management in healthcare, which institutionalizes this belief that people, as much as health workers, but also the users, have to have a say in how their healthcare is organized. And so that was interesting for a number of reasons. It was interesting because while we were researching this a couple of years ago, we were also hearing increasing calls towards participation in healthcare and the importance of putting people at the center. But what seemed to us was that the meaning was completely different. So while in Yugoslavia you had this approach that there was a very, it was very concrete. You had institutional forms through which people should take part in shaping their healthcare. The things that we were seeing then in recent years is very different. It's something that's quite, it's not defined, and it's not actually clear what it means when you say that you want people to take part. Essentially in Croatia, what it means when people say now that they want people to take part in healthcare decision-making is that they should follow a certain behavior which makes them not fall sick, while at the same time ignoring all the social framework that is shaping the health of people that we're seeing. So that was an interesting thing, because we also saw throughout this research that the formal introduction of self-management was a wow thing, because it's so again, it's something that we're not hearing so much about today. On the other hand, it was tricky because it still faced the same problems that we see in the interaction between healthcare workers and patients right now. Because then again, if you look at how people experienced it, they always talked about how, yes, we were there in the same place at the same time with our doctors and with the nurses, but the asymmetry of knowledge was so profound that we had no actual mean for communicating, and this became a big problem. So there was a good attempt to make health more democratic, while at the same time you still had to struggle with the same problem which you have today, which is essentially that, yes, so patients and health workers talk about illnesses in very different ways, but there lacks maybe a really honest attempt to bridge this gap. So there's very little effort put into how people can actually find a language to share and when they talk about health. And then the third and maybe final thing I think that pushed us towards researching this was, again, this kind of trend of commercialization, of privatization that came in even before so Yugoslavia fell apart into these kind of countries. Let's call them countries for discussion's sake today. So the course of commercialization started well before that. We saw, of course, the impact of how structural adjustment and loans pushed the quite progressive, let's say, the comprehensive primary healthcare paradigm that we had in Yugoslavia. It pushed them towards what was there in the rest of Europe. So that was one thing that we thought it was particularly important to address, because with time people lost kind of the feeling of why that's important and why it's important to actually talk about our healthcare being provided by by the private sector. Instead, it became natural for people to say, well, it doesn't matter if my doctor is a private operator or if they're a public operator, but while I receive the healthcare that I need. It was not so before, and I think that's important to say. It took a lot of concentrated effort to change that narrative. And one of the first analysis that we did showed was that there was this really wide-ranging effort to change the language about healthcare. And then that if you look before the 80s, you had terminology that spoke about rights, that spoke about social determinants of health, of people being people having the right to access the healthcare that they need whenever they need it. And then throughout the 80s, you see it changing and people talking about so essentially about the introduction of a market-based logic into healthcare. And that's very explicit. There's no shame in that. People, high-placed people in the ministry go into the media and talk about how people are being spoiled, that they are spoiled because they expect healthcare to be provided at no cost at all. So that's something that, we wanted to show that it wasn't, that discourse wasn't valid for a long period of time. And it's essentially something that gets introduced in the very late 80s or even in the early 90s. And then we have this kind of continuation of the same trend until today, in a very disorganized manner, if I can add. So it's complete chaos because the reframing of healthcare in Croatia and also up to a point in Serbia and Slovenia and Bosnia, Macedonia and so on. So it took a bit of a different approach than if we look at other health systems which were public before and then privatized, because in Yugoslavia it was already decentralized. And so there was kind of a moment of confusion because the trend then was to essentially take a centralized system and decentralize it because it's easier to privatize. So the private sector can pick and choose the sections that it wants. In Yugoslavia, it wasn't so easy to do that because you already had this kind of decentralized system, which first had to be centralized and then broken up again in order to let the private sector in. So this kind of this kind of approach impacted how healthcare had been reformed in the 90s, and it essentially led us to the situation that we have today, which is mostly privately operated primary healthcare, but invisible if someone is not really accustomed to talk about health. It's not something that is visible to most of the patients. It's there if you go and look at where the money goes and who's actually the doctor who provides care.
And Matthew?
Yeah, so we started looking at healthcare in the GDR as part of our publication series called Studies on the DDR. And we published the second study in this series at the beginning of this year. And it focuses on the healthcare system. We started researching the issue sort of during the COVID pandemic because we realized that, the healthcare system in Germany was really collapsing at the time. And it's sort of raised the question of how do you do these, how can one react to such a pandemic more appropriately or more efficiently? And so we got in touch actually with a former GDR physician who specialized in social medicine, which is also what Anna was just talking about, right? This idea of the social determinants of health. And we kind of wanted to understand how the GDR and socialist healthcare in general went about this issue of how do you actually shape these or let's say influence these social determinants, social factors in order to really prevent illness from happening in the first place. And this is what we try to really draw out in this publication that we produced. And we sort of, what we figured out is that a lot of it rests on the idea of socialist property relations, right? So public ownership of the economy is really key in this sense, right? Because if you have the structures of society in a centralized manner, if you can control them in a centralized manner and sort of manage them, then you can also really shape these social determinants, right? So you can integrate healthcare into, the workplace, the schools, universities, the neighborhood, and so on. And in this way, you can really systematically sort of investigate and tackle these everyday healthcare risks, right? So it's in a way, you're taking a very sort of socio-political approach to health policy. And I think that's what enabled a lot of these socialist states to come from a much weaker position. And in terms of just sort of general health statistics, they actually catch up with the West, which was in a stronger position within a relatively short period of time. And so also based on these sort of public ownership, the socialist property relations, what we noticed happened in the GDR, and there's a 40-year history that healthcare came to be understood as something. It wasn't an individual responsibility, but it was very much a social responsibility. And it was just to give an example, checkups for children, for example, were done within the kindergarten and the schools, so that the parents weren't left to organize things like vaccination appointments for their children or dentist appointments and so on, which I don't know what it's like in where you guys live right now, but here in Germany, for example, these are all things that parents have to organize themselves. And in the case of dentistry, this is something that parents also have to pay for themselves. So rather than leaving it up to the parents and also creating this burden for the parents, it was this sort of idea that you could make healthcare and health protection a social responsibility. So also in the workplace, for example, you would have regular checkups. You would also have inspections in the neighborhoods, measuring noise and air pollution, just making sure that everyday healthcare or standards are being protected, so that you can actually avoid illness in the first place. So it's a very heavy emphasis on what they call prophylaxis, right? So preventing illness in the first place. And I think what we also noticed when we were researching this is that Germany is a very interesting example, right? Because you have, after the Second World War, you have two German states. You have a socialist East Germany and a capitalist West Germany. And this allows you to basically contrast between the capitalist system in the West and the socialist system in the East. And really, even though they have this shared history, they depart from they take very different paths after the Second World War. And so it was very interesting for us to look at some of the structures that were really crucial in the GDR. Maybe we can get into those later, but they developed new models of outpatient healthcare, so the healthcare that you receive outside the hospital system. rather than having these private practices of sort of self-employed doctors that are scattered throughout the country or the city, you have sort of more centralized polyclinics, what they called them. And so there were sort of different models that they used to really pioneer a new approach to healthcare that really, as I said, place an emphasis on this question of, social medicine and prevention, rather than relying on self-employed doctors to basically be financially incentivized to treat patients rather than actually prevent their disease, right? I mean, a private physician's office is actually incentivized to have patients keep coming back for treatment, right? You actually want them to stay ill in a way, so that you can keep prescribing the medicine and so on. And so this is, I think, one of the reasons why the GDR case is very interesting. And I think the other aspect that's interesting is that, the GDR, in many ways, you could say it's the only socialist state in the 20th century that was built in the Western world, what we call the Western world. I mean, it was, Germany was an advanced capitalist state. And after the Second World War, the third eastern portion of it then became a socialist state. And I think you have a very interesting mixture then of sort of this tradition of medicine from the West with then the sort of socialist tradition and influences coming from the Soviet Union. And they created a very interesting and I would say very advanced healthcare system in East Germany. That I hope we can maybe discuss in a little bit more detail throughout the rest of this episode. I think maybe one last thing to highlight for the introduction is that the East Germany, just like all the other socialist states in the 20th century, they were operating under incredibly difficult conditions, right? So especially sort of in East Germany, you had obviously the post-war destruction. And then you had these sanctions that were imposed by the West on the East, and sort of greatly hindering, the importation of modern medical technology and equipment and so on. And then East Germany was also footing these reparation bills because the West stopped paying shortly after the war. And you also had an open border between East and West Germany, right? So East Germany is trying to build socialism, trying to construct socialism from 1952 onwards, and for the first almost 10 years, it's basically doing this with open borders and paying these reparations while the West is getting all this money from the Marshall Plan and so on. So I think this is another thing that we can learn from the GDR, is that how do you actually build a healthcare system that's not oriented around profit, but really around serving the people and protecting the people from disease and illness, while operating under these extremely difficult conditions. I think it's similar to Cuba in this sense that, they've proved that even under these really difficult situations, it's possible to actually create a healthcare system that's really efficient and, in a lot of ways, more effective at preventing illness than what you see in, the advanced industrialist states in the West.
Thank you so much for the introductions. So one of the interesting things, so I mostly have done some research on the transition from Soviet Georgian healthcare to capitalist, whatever, different stages, different kinds of levels of intensity of liberalization in Georgia. But what was interesting for me was thinking about 1917, the Russian Revolution, and the insane amounts of hardship, disease, complete collapse that the new revolutionary government was facing, and how they respond to it, as opposed to 1991, the Georgian government also facing collapse, but even less so because you actually have an infrastructure already built, unlike 1917 when you have nothing. And the most, so-called, talented specialists are leaving as well. And so how did these two governments meet these demands? It's like, the the revolutionary government prioritizes and understands that capitalism brings sickness. This is, of course, you have all stated this, that this is, poverty brings sickness, and then you have to sort of cure at the roots of things, the social determinants of healthcare, if you want to say of health, and really prioritize this sort of holistic way of people need, homes, they need hygiene, they need someone to teach them how to do things like wash their hands or, like basic hygienic kind of codes and so on. And then to create, as many clinics, hospitals, train as many nurses, and to make sure that there's enough doctors and nurses available for each, population. Now you have 1991, and it's like, let's completely cut all healthcare. You will also have, new cases of TB and all these diseases that have been cured spring back up. And then you have, some international agencies like lend a hand and give a little bit of money to put out the fires here and there. But really, the overall thrust of the neoliberal sort of governments is that we have to cut costs. That's the most important. We have to privatize. We have to sell everything off. If we don't sell it, we just like let it go to waste. Fire all the nurses and doctors that we can, and just every man on his own. If you don't have the money, it's too bad for you. And creating these, even the state-run places were just like kind of like a bazaar. Each doctor was private under the state owned infrastructure, which led to, if you look at all the things we've studied and seen, like 89 levels or 88 levels. And now is almost every single illness, health indicator has worsened in the last 30 years. We compare this to the Soviet Union, 30 years, they had increased longevity in incredible amounts. It was like 27 or something was the average life expectancy in like 1917, something incredibly low. To raising the life to standards, and actually also having fought World War II and won, you have still just things, besides the slight drop in life expectancy because of the war, you have almost every single health indicator, social sort of indicators just going up and up and up. So just seeing the two different ways, it's not just about like money, it's not just about the resources available at the time, but it's actually having the politics to believe that you should actually care for people. This is your responsibility, and to look at health as part and parcel of a larger project of communism makes all the difference in the world. Apparently, just to look at the kinds of economic and other problems that they were facing, different types of government. So while I was thinking about all of this, I wanted to ask all of you, is like, how much does this idea of money, having the financial resources, because it's always reduced down to this money equation, how much does it actually affect healthcare in a sense? Like, how do you sort of make sense when people say, well, we have to get rid of these, large, overblown, bloated, states, infrastructure and so on, cadre, to make room for a much more so-called efficient healthcare. So what do you to make of this sort of discussion, this idea of finances not having money?
Yeah, okay, so I can have a go, because it is a very, it's something that's very present here. And I would add that, while there's this kind of talk about the importance of reducing costs, there's also talk about how important it is to have a high-tech health system. And that's essentially, when we talk to people who are involved somehow in health policy making here, the response that you get when, for example, you bring up the example of Cuba, and you say, well, Cubans don't have much money, but they have a health system which essentially responds to people's needs. Is that, but they say, but yeah, but they're poor. It's not really healthy. It's not really a health system if you don't have all the up-to-date health technology. And it's a very problematic thing for me. I think that we lost this kind of conception that health is much more than whether we have 7 MRs in each hospital or we don't, because we had experience, so in Yugoslavia that it can be a much more effective health system at a much lower cost than this. And I think one of the most important things that we notice that when we talk about primary healthcare, so in Yugoslavia, it was addressed because it was seen as an efficient health strategy. So they were saying, we're doing primary healthcare because it works. It makes sense. It's something that will help people to lead a better life. Today, at least formally, there is also this kind of focus and fixation of primary healthcare, but it's most exclusively framed in this discourse that we have to strengthen primary healthcare because it costs less than hospitals costs. So that's, I think, one of the main problems that we're facing here. But also, I think that because of this change of discourse, is that there has also been like a collective forgetting of how health infrastructure was built before, because it wasn't so. It was up to to a large extent it was public investment. So to build hospitals, to build maternity wards, and so on. But there was also a very strong drive among people, among workers, who pledged part of their salaries and pledged part of their income to build local community health centers. So in the area where I was born, you still have health. They're called health stations because they're a bit outside of town, so they might be a bit more difficult to reach. They might be for a rural population, and you still have tables which state, so this building was built because the workers, the farmers, whoever of this area essentially wanted to have a health center and were able to contribute in some way. Sometimes it was money, sometimes it was essentially work. So people went to work to build the health stations that were there. If you compare it to what I think we're all hearing now, is that essentially there is no money. And yet money is essential to build these high-tech hospitals that we all need. So it's a bit of it's like an attempt to confuse people, I would say, because we still do have health workers who experienced a completely different system and a different approach to healthcare and a different way to live healthcare and to understand what it's supposed to do.
Yeah, I would maybe build off of what Anna was saying, actually, because I think, this question of having enough money for healthcare, I mean, this is a bit of, I guess, what you could consider a paradox is that Germany today, right, is a leading country in the EU, or is the largest economy in the EU, and it is its healthcare system is going through a major crisis at the minute. I mean, waiting times are a disaster. There's a shortage of doctors. There's a shortage of staff. The hospitals are closing. There are not enough beds. And the clear reflection of this was during the COVID pandemic when, the healthcare system was really brought to its knees, which is shocking considering, as I said, it's in theory, right, it has the most resources available that maybe any country has for this kind of pandemic response, right? So I think, the idea that you can just throw money at healthcare and then it will be, more efficient or more effective is kind of an illusion. I think what really matters is the structure of the healthcare system. This is one of the things that we noticed when researching the GDR is that, they nationalized the healthcare system originally, and then as time progressed, they began also nationalizing other sectors of society and the economy as well. And through this, you basically had a very sort of centralized, unitary system of healthcare that was led by the health ministry, right? So you didn't have this sort of fragmented system like we see in so many states today, where you have sort of publicly funded services on one hand that are rather weak and underfunded, and then you have sort of privately organized care facilities, some hospitals, and so on the other. There's not a lot of coordination between these different sectors. They're sort of all profit oriented as well, and it's just there's no real leadership. There's nothing that's coordinating the system in a really unified, unitary manner. And this is something that was completely different in the GDR. All of the healthcare facilities, or even just health institutions in general, right? So hospitals, clinics, also pharmacies, research centers, university research faculties and so on, they were all part of this unitary system, and they could respond to the issues when they came up, implement the decisions that were made by the state and by its decision-making structures and so on. So I think the idea that you can throw more money at it is not is the wrong way of looking at it, right? It's much more got to do with the structure of it and how you go about it. How you actually conceive of a healthcare system for society in general. And I think here, the crucial thing is that healthcare, it cannot be oriented around private economic interests. It has to be oriented around the needs of the people. And this is something that you never have in a capitalist state. And maybe just to add to one thing that Anna was saying that I thought was interesting, this idea of primary care as being cheaper than inpatient stays in hospitals. I mean, I think that this was in the GDR sort of unspoken truth that people held, that if you can avoid an inpatient stay, it is actually more economical, right? It's more economical to prevent illness in the first place. I mean, if your healthcare system is based on profit, you don't want to prevent people from getting sick because you want to charge them for the treatment. But if you actually, as a society, prevent illness in the first place, then you can have a healthcare system that's a lot more economical. And you can see this in countries also like Cuba or the GDR as well, where like I said, they have a lot of sanctions, issues with sanctions, so they can't import the technology, and at times couldn't afford it either, even if they could. So through this idea of prevention, you can actually create an effective healthcare system without actually having to throw a bunch of money at it.
Maybe if you have some information about the supplementation to healthcare with the resort system, let's say, what role did these resorts, sanatoriums, play in preventative healthcare in Yugoslavia and GDR? If you have information, of course.
Maybe, I can say a few words about it. We didn't look at the resort system in much depth. They were called Kur. You still have them in Germany. But yeah, basically the idea is that, obviously you can have a resort Kur stay after treatment, as part of what they call rehabilitation, right? And again, in the GDR, because you had these socialist property relations, because the system was unitary, it meant that you could sort of integrate, prevention, treatment, and rehabilitation. And so when a patient is maybe sick, the whole process of then treatment and rehabilitation is sort of coordinated, right? So you can, a doctor is in contact with these resorts where they can send patients and so on. And then the resort that receives the patient is then, they have all these patient files, because it's a unitary system. It's not like a private resort where the patient then has to deal with all of this kind of bureaucratic side of things, right? But in the GDR, you also actually had preventative resorts, like what they call vorbeugende Kur. So before patients would even get sick, you would, if they had a stressful job, or a difficult situation in their life at that point, they could go to one of these resorts, often at the seaside, at the Ostsee, the northern part of Eastern Germany, and basically have a couple weeks longer to make sure that they wouldn't get sick in the first place.
I must admit, we didn't do much research into this, but so just thinking a bit about what we're seeing, like building from what we're seeing now. Yes, so there were just linked to what Matthew was just saying about, workers having the possibility to go somewhere which is publicly owned. Like most of the factories, most of the major employers had that kind of infrastructure on the seaside. So, if you were working for a factory, you were essentially guaranteed some time off during the summer where you could just go on vacation. So it was definitely that kind of thing has its health, at least, mental and physical health benefits when you look at it. It's very rare now because people cannot actually afford to go to use that infrastructure. It was all sold off at some point. So that was one of the, but okay, so maybe that was one of the things that we didn't really analyze through the lens of prevention, because prevention was mostly done through territorial services, and let's say through the service of community nurses services, which started operating quite early on. And so that part was mostly about reaching out to people's homes, especially in working class neighborhoods, because it was recognized very early on. And that's, if we look at the reports of some of the community health centers, like 10 years after the Second World War, then you see, how they're talking about working class neighborhoods having very bad social determinants of health still. People are living in very crowded conditions. They're living in basements. They're living in attics. It's all humid. And so essentially the prevention here was, on the one hand, more social housing, so improving the living conditions, but then also mapping through the community nurses services the situation that was on the ground. So the idea of having health workers who got to know the workers and who got to know their families and could identify then their health needs and address them to the different polyclinics or ambulatories or dispensaries, whatever people needed at that point in time. So that was, that was the broadest, I would say, attempt at prevention that Yugoslavia saw at this period of time. And then third, of course, there was this pool of public infrastructure for rehabilitation mostly. So things that would include thermal waters and pools and so on and so on. You still have some of those which are publicly owned. But the problem now compared to before, although it's always crowded, of course, is that it's very difficult to get there. Not only because it's crowded, but also because doctors are implicitly disincentivized to send people to rehabilitation to use the services, because it's seen like supporting time off work. It's like perceived as free time off work, which is not necessary. So essentially, you have this problem where you see the public infrastructure which was built for this purpose, which is either being underfunded or it's being stigmatized in that way. So it's not really it's not accessible to the people who need it mostly. And so essentially, if you need this kind of care today, you're forced to go to the private sector. So that's you're forced to pay something.
The resort system was quite extensive also in Georgia. It's absolutely not available anymore unless you pay out of pocket whatever is left. There are not that many left as well. There's all these new adventures to convert them into like 5-6-star hotels here and there, the ones that they like. And I was recently in Borjomi, which was like, it's like a health resort place. Oh no, Sairme, sorry, there's another one. And I went, they have like free consultation where you can go and drink these like waters that come out, and they have all these stations where you have different kinds of mineral waters and tell you what the makeup is. And they prescribe these mineral waters like 3 times a day. And there's like different kinds of mineral waters. And said that you have to, no matter what, like the full course, of treatment is, minimum 10 days that you have to drink these. And I'm like, who can afford to stay here for 10 days, And she's like, not that many people. Like, so this, like, now it's just like symbolic almost. Like they still have this, and they even do like free consultation or like really cheap consultation, but it's, no one can actually afford to go there unless they're already kind of wealthy. It's all private and very expensive. So it's just so many examples of these kinds of things that can give you where, it's completely gutted. From miners who used to tell me they used to get, like, I think like about 30 days they can go to these resorts and rest because it's such a really horrible work life, and, to avoid like black lung and all these other problems and Parkinson's and so many problems that they have, just to be able to go. And also just these resorts, these sanatoriums were also a place where they would mingle with other people from the Soviet Union. So it kind of promoted this multiculturalism where they could meet people. Some fell in love and got married, some became friends and so on. And so even with the abolition of all these treatment centers and resorts were also bad for health, but also bad for being able to meet more people and see others and see them as equals or from the same place, instead of what we only understand now is like wealthy Russians coming to Georgia and we have to serve them, right? Or like the Central Asians we barely see anymore, very few. There was actually some in the resort areas still, which I thought was very interesting. They remembered and they still have that like culture. So it's just like being reduced down to now Georgians, very, kind of more insular, very poor, cannot leave the country anymore. And anyone who comes here is already kind of upper middle class. And usually we're in the hospitality service trying to serve them. So even that kind of level of being able to meet people and get to know them for 30 days and is gone. On top of that, which also promotes this sort of ethno-nationalistic culture as well.
But can I jump in there? Because I think there's, for example, something that we're seeing here, kind of maybe a bit related. So I think it also worked on a very local level. So, this kind of mingling of people into health services. That's also one thing that I would say stopped at some point because of practical reasons. So one of the first things to go after 1990 was the system in which people were allocated to the primary healthcare doctors, so to the GP or to the gynecologist or the pediatrician. And in Yugoslavia, it was, you lived here or you worked here, so your doctor is this one. You don't get to choose. It's a doctor. They're trained to care for you. The assumption is they're all trained the same way, so they're all equally competent to care for you. That's the thing that goes out of the window. So the first thing that they say is, oh, well, okay, so now you can choose your doctor. And so you have, the usual thing that happens is that, okay, so some people will choose, again, accordingly to the logic, I live here, so I want my doctor here, or I work here and I want my doctor here. But then there's a number of people who will say, well, I heard that this doctor is good and he cares for my wealthy friend, so I might just as well go there. And so it's kind of, it affects healthcare, I would say, in more than one way, because at some point you have doctors who don't actually know their patients anymore because they're either overcrowded or essentially they get people who they see once in their life and never again. And then on the other hand, you get doctors who get a lot of patients because they're popular, if we can call them that way. Just like schools get popular because word gets around that, they have hip teachers. So just as we have hip teachers, now we have hip gynecologists, which is kind of a problem. And it's essentially not reflective of the quality of care, as it's not reflective of the quality of education that you can get through this system. I think it's one of the things that change how people perceive healthcare mostly. I think that, they will say, now you can freely choose your doctor. This is freedom for you guys. Before, you were forced to go to a doctor somewhere because it was close to you.
Yeah, I think this is actually, interestingly, one of the ideological talking points these days. I mean, actually in the GDR, it was a bit of a special case within the socialist camp, because you still actually had, well, to a certain degree, freedom of choice who your physician was in the socialist GDR. But today, one of the big arguments is, of course, like, oh, well, today you can choose your doctor really freely in Germany. And when you try to find a doctor, you realize actually you can't choose one because no one's taking new patients because there aren't enough doctors. So I think it's just one of those, this question of choice and the sort of counter point, or the opposite of this is like mandatory. This question of everything in the socialist states was mandatory. We looked at, for example, also vaccinations, this idea of what is a mandatory vaccine and so on. And what we realized when we researched it is, it's not so much, it's not like these vaccines are forced on people, but it was basically an opt-in system. So it was mandatory for the state actually to provide safe vaccines to all people. So, this relationship of what's obligatory, it was a two-sided thing. It's not just that the patients have mandatory vaccines, but the state is also obliged to ensure that this is actually realizable. And I think it's something that's so often left out of the debate these days, that actually here our society, the state, is failing its obligation to deliver adequate healthcare. And you can see that in other sectors of society as well, education and so on. And it's kind of hidden behind this idea of choice, right? You can choose which school you send your kids to, you can choose which doctor, so actually you're more free. But of course, the reality is that everything is full, everything's expensive, and at the end of the day, the quality of the care or the education is actually worse.
One, of course, very important component of the socialist world that both Yugoslavia and GDR were in was this idea of, and maybe they were in two different parts of the socialist world, but the greater socialist world was about this idea of internationalism. And internationalism, of course, was not just like an ideology, but had these material implications. And one of the ways that it had a material implication was the fact that socialist states, such as the GDR and Yugoslavia, were, assumed responsibility for helping specialists learn things and then go back to their states and bring the skills that they learned in Belgrade or bring the skills that they learned in Berlin back to the states that were in the time of decolonization, especially oftentimes third world developmentalist socialist states, and they could bring this kind of expertise back. And this was the real, one of the material expressions of this kind of idea of socialist friendship between nations. And, I'm curious. And so I say all this to lead into the question of, in both of your research, what role did this internationalism play in the health systems of each country, in the sense of foreign students coming and learning medicine, or the inversely, doctors or healthcare professionals from the Yugoslavia or GDR going abroad? Because one of the interesting dynamics, to bring it to Georgia for a second, is that today in Georgia, we see that there are students from the Middle East or from Pakistan or from India who come to Georgia, or even Palestine actually, come to Georgia and study dentistry or study medicine. But what's interesting is that, you know, in this hyper individualized capitalist world, they come to Georgia because it's cheap, and they come to Georgia without some kind of, like, you know, shared vision of a world, even in name. It's like they come because of the market. So I'm curious, like, in both the Yugoslavian GDR case, how internationalism played into medicine.
Yeah, we actually we produced a different text on this as well, which is on our website. You can find it there in several languages. And what we did is we actually spent quite a bit of time researching the school that was in the GDR, specifically for this purpose, for training young students from the global south, from national liberation movements or newly liberated states, to basically receive an education, a medical education in the GDR, and then return home so that they could help build their own healthcare system, which, of course, in this sort of post-colonial context is vital. Without healthcare, there can really be no social progress. And oftentimes, when these colonial powers retreated from their territories, they took the infrastructure with them, they took the medical professionals with them, because they weren't educating the local population. So what we noticed in this text is that the GDR was just one small state in the wider socialist camp where this was happening, right? But there was thousands of students coming, receiving education, with the explicit purpose of returning home. In Germany today, obviously, there are also quite a few students from global South countries who come here. But oftentimes what will happen is, first of all, they have to organize this education themselves, which means oftentimes they have to have the financial resources, which in the GDR was actually made available to all of these students. They had a stipend, they were part of the healthcare system, they had all the resources they needed to focus on their studies. So this is the first issue, was how did these students actually get to study in social states? And it was through sort of agreements, right? Political or state level agreements, or with mass movements in these countries, with the explicit purpose of these students returning home, right? So they weren't coming to Germany, for example, like a lot of students do these days, and then they become a doctor in Germany and they send maybe remittances back home, but they actually return home so that you can gradually overcome this relationship of dependency, and actually have a stable, really solid healthcare system in these countries that are sending the students. And so, I could definitely say that in the GDR, this was a huge program, and sort of a central pillar of international solidarity. And of course, it should be said as well that this wasn't merely charity. First of all, there was this sort of learning from each other. So a lot of students, for example, from tropical regions would come and bring expertise on plants, medical plants, and so on, that were then part of sort of cooperative, collaborative programs with GDR universities and so on. But it was also seen as part of the wider anti-imperialist struggle generally. It was seen as a way of undermining the influence of imperialism by helping these newly liberated states become, truly independent, no longer reliant on medical aid from the West and so on. So, it wasn't just some kind of Christian charity or something. It was really part of a struggle, which the GDR saw as against a common enemy in imperialism, who was also imposing, all these sanctions on the socialist states as well. So, I would say it was certainly a central pillar of the medical system in GDR.
And I don't think there's much to add to that. Maybe just one element, which is parallel to the education project. And so what I found very interesting while we were looking into how Yugoslavia interacted with other countries when it came to healthcare was that there were also projects of exchange at the level of health system planning. So, for example, you had delegations coming from Iran to Yugoslavia to see at how the primary healthcare system worked, and then you had delegations from Yugoslavia going to Iran to to see how many of the elements can be implemented and what needs to be changed. But the key point here is that there was always room and there was always an understanding that something that worked in Yugoslavia did not necessarily have to work in the same form in any other country. So there wasn't this concept that we have this perfect healthcare system which works and now we just go and copy paste it everywhere. We have a health system which can serve as an inspiration to people, and from which they can take some of the elements that are appropriate for for the local context, as compared to now, where essentially the Croatian health policy is based on a copy-paste approach primarily from West Europe. So this has been a major shift, to how you perceive healthcare in society and how much freedom you have, both to shape your own, but also to support others who are building their own health systems. That's.
One other interesting dynamic I wanted to discuss was obviously in Yugoslavia there were elements of worker management project very famously, another kind of like elements of decentralization that didn't exist in other state socialist experiments. That aside, obviously in both the GDR and in socialist Yugoslavia, there is an ideal of social ownership. And there's an ideal of, capital itself is not the engine of development, common property. And one of the things we see, obviously, especially in the post-socialist world, is a wild capitalism that is very detrimental to people's health in many different ways, right? And some of this is infrastructural, where they decide to build homes, what kinds of laws have been repealed that previously would have prevented, for example, where people are living, how people in the work process are being exposed to certain kinds of chemicals. We know for a fact in Georgia, the regulations for minors is much, much worse. And so this leads me to a question, and if either of you have researched this, is, how do you see the socialist approaches to living conditions and the labor process relate to kind of a social provision of trying to ensure people's health versus the kinds of dynamics you see in the post-socialist regimes? And so what I'm asking is not so much healthcare provisions at the hospital and at the doctor's office, but the way that you see sort of like a social engagement with protecting people's health at their place of living and in society and at the workplace.
Yeah, I think this is what I was kind of trying to get at earlier as well. Is this question of public ownership, as I think it's very much the key to understanding socialist healthcare. I think Sopo, for example, when she was talking about healthcare in sort of post-1990 Georgia, it's like putting out fires, it's very much the same thing in Germany today. It's just a very sort of reactive approach where you're sort of running around trying to fix what they call market failures. But I think what we really need to understand is that if you have public ownership in the economy, you create sort of a framework for discussing and coordinating these health objectives in relation to, the other objectives in society. So your political objectives, your economic objectives, your social objectives. By having this public ownership, you then create this medium through which you can actually weigh up these different factors and decide which is the best approach. There were a lot of issues, for example, in the GDR as well. They had to reindustrialize the country, right? Especially since most of the heavy industry was historically in West Germany. They had to essentially create their own industrial base. And this put a lot of pressure on workers. The working conditions were not great for their health. You also had the issue that, for example, there was no real natural energy sources in the East. The coal mines, they were all in the West as well. So the East Germans, they ended up burning this lignite coal, which, brown coal, which was incredibly dirty. It was a horrible pollutant and things like this. So it's not like, they got rid of the profit motive in healthcare and then overnight everything was fine. That's not the case at all. But the thing is that by having this public ownership in the economy, you could create ways of, for example, minimizing the impact of these detrimental effects on people's health. So, for example, they had these workplace inspections so that those workers that were, exposed to real hazards and, chemical hazards or, maybe strenuous work, that they could then also receive sort of tailored care through this occupational healthcare system, which again is part of this unitary healthcare system, which means it's not actually part of the enterprise, but it's independent of the enterprise. It's managed by the Ministry of Health, which is different to occupational healthcare in the capitalist system, which is oftentimes part of the company, and their objective is basically just to get the workers fit enough to go back to work. Well, if you have an occupational health system that's at once in the workplace, but at the same time independent of the management of the enterprise, then you can actually create a system that's really looking out for workers themselves, right? Because this is the way it was in the socialist societies, is that the people were, they were the focus, they were the center. That was the whole reason for economic progress, was to improve the conditions of the people, not to generate profits. So this is kind of the framework, I would say, that enables society to really cautiously, actively shape society around people's needs, around their health, and not around profit.
And again, I think this is quite similar to what we saw here. And then definitely, also there. Let's begin with saying that there was quite a strong focus on the industrial sector. So if you had workers in factories, for a long time until the 80s, the late 70s, let's say, the focus was on strengthening that part of the workforce. So, on securing access to healthcare for them in the factories. And if you look at the space that we're surrounded by, you can still see traces of how this was organized and how it worked. There were doctors and there were nurses in the bigger workplaces, which again had a very similar aim to what Matthew was just describing. It wasn't just, for example, somebody's hand gets cut off at work and they're there to stitch it up and then just, send them back to work. But it's essentially also about prevention, about tracking what's happening in the workplace that can affect people's health, keeping track of the working rhythm, of how, for example, work in shifts affects people, how prolonged working over the night affects the health of people. So these were all things that were there in the workplace for a very long time. On the other hand, one of the bigger problems was securing access to healthcare for the rural population and for the farmers. So that's one of the things that we need to say that were not addressed in the most proper way. But also it's fair to say that there was not time to address that in a more effective and efficient way. So there were some, there were gaps in the health policies that were implemented at that point. But the important thing is that, yes, the priority was in the right place. So, the priority was people's health. It was securing a healthy population, not just so that we can have a healthy workforce, but because a healthy population is something that, people deserve to, it's something that people deserve to see. So I think that's one of the key issues that differ from today. So if we look at how, again, occupational health is treated today, it's not treated, it's not here anymore. So it's not something that's perceived as important at all. And the very few occupational specialists and services that you do have are, for some reason, privatized. So, in order to get this kind of assessment by a doctor who can say if something happened at work or not, you're forced to go to a private clinic. So again, that's something that most workers cannot actually afford to do. The whole shift has impacted. Yes, so essentially it has meant that we move health from a well-being framework to the market sphere. And it's not only occupational health, but it's also children's health, for example, or students' health. As occupational medicine got eroded, so did health services for students and for school children. So this is something that, it's that also builds up over time. And it essentially means that at the point when you go to a doctor, your health might already be so eroded that it will be more difficult to get you the help you need. Without proper care while you're at school or when you're a student, you cannot actually expect to see a healthy adult population which is informed about its own health, and it's actually informed about what the health system does. It's then just treated as a pure service. You go to a doctor because your head hurts. You don't go to a doctor because you know that you've been living in a bad apartment with mold or something, and you're aware that it's not only about the physical health, but it's also about the society that's shaping the conditions where you live in. So that's, I think, a major shift that happened over the course of time.
Yeah, if I could also speak to this about occupational health and safety and occupational medicine in general, labor medicine. Again, through conversations with what is now considered an institute that has zero power because the entire occupational health and safety mechanisms were destroyed in the early 2000s. They have zero power. So these really wonderful Soviet women sit on top of this huge knowledge, completely unable to influence anything. They don't have a mandate to go in any factory, any workplace. They really are not allowed to do anything. They're just sort of symbolically kept on because of a favor of some politician, and they reminisce about the Soviet Union. And they tell us these things that were just fascinating because, it's like during the Soviet era, about 200 occupational diseases were diagnosed a year, about 200. Now it's zero. And on top of that, last time the director had made a diagnosis, she's a doctor, and she said that through mining, these two people had Parkinson's that had gotten it through years of mining. The company called and threatened her, and she never made another diagnosis ever again. And so, to go back to what Matthew was saying, is there was a unitary system where there were doctors, nurses at every single level, including the factory level, workplace level. There was constantly recording any kind of ailments people had. There were these occupational health specialists that go in and study long periods, the effects of, say, whatever, drilling, noise, vibration, and so many other things that we don't even think about. And so all of this is gone. Even if you try to give some mandate to these women now, this institute, then there is this protection. They're using things like personal information protection. There's this or that to try to keep the sort of government, so-called government hand out of these enterprises. And so we go from a rich, vibrant, preventative, and also richly studied occupational health and safety and labor medicine to zero very quickly. And then all these workers are left to their own devices to get help if they need it. Of course, most people are like me. They never go to the doctor unless they're dying, because we are afraid of doctors, and also because we don't really interact with them. It's too much money. So you're like, I'm just going to take my chance of dying. And so then it's called like, oh, it's like a man thing. You know, they'll have like studies be like, this is a masculine trait not to go to the doctor. And it's like, well, it's because there's no infrastructure at all to get people in, and especially men who need to keep working, you know? And so, I don't know, it's incredible how at this point, when you had such a rich and vibrant healthcare, and, you know, of course you have a political project, the utopian, beautiful project of communism with it, but it's completely demolished. And now everyone goes to Turkey to get basic, you know, care. And how would you rebuild that? You know, I constantly think about how you would rebuild that. Like, for no reason, all of this was destroyed. And how do you even go back to even under these sort of capitalist conditions, how to even rebuild a modicum of what was lost?
No, I don't actually even know where to start, but maybe from a reflection that I also had when we looked at primary healthcare here, and that was essentially that it took them a long time to destroy that, at least in Croatia. So it took about 30 years to completely dismantle the primary healthcare system that was in place. And even today, it's not a complete dismantlement. So you still have it was so rooted in the community, and it was so rooted not that much in the feelings of the community, but in community life, that it was essentially impossible to just do without it overnight. I'm not saying that they did not try, but you still have traces of the things that worked best, and the things that essentially are not translatable into a capitalist world. So, you know, if we look at the health centers right now, we do see a lot of private general practitioners working from the health centers, but it's still impossible to, for example, privatize the community nursing service. That part is still public, because how do you translate something like that in a profit-driven logic? Nobody would do that. And yet it's so useful, and the people relate so much to that kind of program that it's not something that you can just say, oh, well, that's not going to exist from tomorrow anymore. So I think while it is true that overall the health system has been completely destroyed throughout the past decades, there are still traces of things that we can use to rebuild. And I think this kind of feeling of what's important in healthcare, and the understanding that health is much more than this kind of technical approach, which is just here to fix people when they're broken, still exists, and people still relate to that part. I feel that since a couple of years, maybe even more than they did 10 or 15 years ago, because there's been a lot of more frank and open discussion about why we have the health situation that we have right now, which again, as Sopo was saying before, you see health indicators which are worsened compared to what they were before. They're definitely not in line with what other countries are seeing. So there is both the legacy of well-organized healthcare, which still lives, at least unconsciously, and on the other hand, we have the understanding that it doesn't have to look the way it's looking today. So that's, I'm not overly optimistic about anything, so about this also, but I do think that there are things which can be used to rebuild.
Yeah, I mean, I think one of the important issues or factors that we haven't really talked about yet is actually the employment conditions for healthcare workers in the socialist states. I think it's one of the central issues here in Germany, at least. I'm sure it's like that in most countries right now, but these kind of strikes that we're seeing across the world of healthcare workers, nurses, and doctors also demanding better pay and so on. I think one of the things that we discovered when researching the GDR system was in terms of this sort of employment of doctors or their employment relations, was that it was recognized in the GDR that private employment, especially in sort of primary care or self-employment, is dangerous because it's like I said earlier, you're financially incentivized to treat patients rather than actually prevent their diseases. And while we were researching this with Dr. Niemann, he actually told us that this was not really a particularly socialist discovery of this. They were talking about this actually in the 1920s already, at least in Germany in the Weimar era, that we had to kind of overcome this model of private self-employed doctors in their private practices. And I think that's one of the really impressive things about the GDR is that this was a process. Overcoming this model was very difficult. There was quite a lot of resistance, especially from sort of conservative doctors, physicians, like associations and so on. But they basically overcame it by sort of showing the advantages of public employment. And especially towards the end of the GDR era, sort of the late 1970s and 1980s, you have this employment relations in this healthcare system where physicians, nurses, they're employed, they have their same rights under their labor code, they're part of the same union, and so you have sort of this way you're also overcoming this hierarchy that you see in many healthcare systems today, where physicians, they're organized in their own associations, nurses are then part of a union, and there's a bit of a confrontational relationship between the two groups. You really didn't have that at the end of the GDR era, because you had a sort of a new collegial atmosphere, because the people who used to be employers and employees were now all of a sudden colleagues. And I think this really actually helped to improve the situation within the healthcare system itself, because the people working there were not under such tension, and they were also sort of freed from their financial dependency on sick people coming to them, so they could really focus on preventive care, and they enjoyed a reasonable income, oftentimes with sort of fixed salaries. They had holidays that they could enjoy, and also oftentimes they had holiday sites, camps that were provided by the union, and so it was really a different employment structure there. And I would just be curious to hear whether Anna or Sopo had looked into how the situation was for physicians in Yugoslavia, or nurses and carers also.
Really important point. I don't know fully well how it worked exactly in Soviet Georgia, but what I can say is, looking at it now and going back to sort of like what is it now, makes me think through conversations, especially with nurses, and now there's sort of like superstar doctors that exist. Often the doctor owns the clinic, and he's the owner and the doctor. And so there's a lot more hierarchy now within these clinics than there was before. The nurses are absolutely not listened to, and the sort of orderly / like hygiene workers are completely treated like not even human in this sort of hierarchy. The doctor is usually like a manager, very much, and then there's an administrative capacity that has been introduced in all this. So the administrators are actually the ones determining even functions of the doctors, if it's not like a smaller clinic, if it's like the big, Bank of Georgia owned enterprises, because a huge part of the market is just owned by banks here, one bank in particular. And they really want to reduce this down to sort of a science of like administration, like not, and take away an autonomy of doctors and nurses. And then as opposed to that, there's a sort of more doctor-centric, but still very hierarchical clinics as well. What from a very small pool that my colleague interviewed, it seemed like the very, very few, like just a handful of public hospitals that are left, the nurses seemed like they were listened to more and felt better about their role than the private ones. And again, this is not extensive research, but it's what seemed like from the conversations and the surveys that we had done in Solidarity Network, our union. Same time, I think this idea of, because everybody now in Georgia, a huge part, believes that there should be profit in healthcare, which wasn't always so. Like over the years, it's gotten more and more this way, because there are studies done even by like pretty right-wing organizations that doctors are like, no, there should be no profit in healthcare. And then slowly it has shifted more and more to, this idea that doctors will be owning their clinics. So they've embraced it more. And as well, if you look at one of the weirder statistics, is that the amount of doctors we have now, like enrolling and becoming doctors, is significantly higher than it was in 1989, because everyone is trying to be a doctor. While we're don't have like a third of the nurses that we need, it's because the doctor is an entrepreneur, right? So everybody's going in wanting to be this. They could also move to another country and have higher incomes and also own a clinic here. So there's a lot of market incentive, even though not market demand, to become doctor, so that you can then be an entrepreneur. And this kind of was really interesting. I have been going on this binge of watching the opiate crisis in the US. Like I became obsessed with, I watched like hours and hours and hours of this. And it was this really interesting point where it said like this one drug representative that was getting all these doctors to prescribe these incredibly unsafe, highly addictive opiates. And the drug rep said, we had the best luck with the doctors that thought of themselves entrepreneurs. So it's such an important part of how people also conceive of themselves, their roles. So the doctors that thought of themselves entrepreneurs were much more likely to push these dangerous opiates and kill people, because they looked at it as like a market and they're just a provider on this market, than the doctors that thought of themselves as people who care for their communities. So the doctors were deeply embedded within their communities. Like this was in West Virginia, was a mining town, right? And felt a sense of responsibility for their patients because they're known and they had sort of community pressure as well, right? They were harder to turn, let's say, than doctors who did not see themselves this way. So these things sort of tell me that it is incredibly important to, I think, this sort of petit bourgeois consciousness that comes up with being doctor needs to be suppressed, because it doesn't produce the results for patients that's necessary. So I don't have a lot of the answers as far as how the Soviet Union was organized that way, but it does look like it was repressed, these petit bourgeois sort of tendencies. Even though I do think in Georgia, a lot of these, like, I do think there was a lot of leeway, I think, as far as opposing a lot of these sort of Soviet style, because they did they did, in general, promote a lot of individuals, let's say, sort of glory and fetishization of individuals that did happen in Georgia. But I cannot give you definitive answers. There's some of my thinking.
Yeah, I also, I mean, maybe just to add a couple of things. I mean, I think this is one of the very tricky issues that the GDR had to deal with. You know, this sort of, as you're saying, the self-understanding of the doctor as like as an entrepreneur. You know, especially in the early years, this was something that took a lot of work to get over it. And you know, as I said, there was quite a lot of resistance from these conservative physicians associations who, yeah, basically wanted to keep this outdated model of the private practice because, of course, they felt in charge. They didn't have to deal with colleagues, and they could be, yeah, basically prescribing medicine at will and charging the patients or the insurance system for this. And so there was sort of a period, especially when the border was open between East and West Germany, where East Germany was having a very difficult time sort of making compromises with these private physicians, and at the same time trying to create this pioneering system of medicine, which, you know, over the years they also addressed by basically trying to raise a kind of a new doctor, you know, sort of, I guess, what's embodied by doctors like Che Guevara or Maxim Setkin, who was actually in the GDR. He's the son of Clara Zetkin. He was a physician who was trained in the Soviet Union and helped to construct the healthcare system in East Germany. And these were kind of, there was a sort of a new generation of doctor that they were trying to raise, especially from working class and peasant families, who would then sort of see the merits of this public employment system and not be so dead set on this old, outdated model, which was actually counterproductive just in purely medical terms, right? So there was this sort of dual approach of making compromises with the conservative doctors and also rearing a new generation of doctor who saw the benefits. You know, like as I was saying, public employment, you know, you have a safe contract. You don't have to worry about running your own practice. You also have fixed hours. You have holidays. You have, people who can step in when you're sick or when you're on holidays. So you don't have to find other doctors in other practices that you can refer your patients to, and so on. And I think this was also something that over the years physicians just came to appreciate, that actually the system is more efficient. And so it was a model that by the end of the GDR, you know, they had actually overcome this private practice model of healthcare. And I think it was actually a great achievement. And, you know, coming back to now sort of the post 1990 world, they just really eradicated all of these achievements in the GDR. I think in contrast to countries like Yugoslavia or even Georgia, where there was a sort of a gradual transition. You know, in the East German context, it was essentially annexed by West Germany. You know, it wasn't a reunification as such. It was more an imposition of the West German model onto East Germany. So, you know, all of these, this long process and, you know, struggle really to overcome private practices was just sort of undone overnight. And they were reimposing this old model onto East Germany, which, as we saw during the COVID pandemic, really showed its weaknesses. And still today, you know, just finding an appointment, things like that is just remarkably difficult in Germany today. And of course, it's having serious implications for people's health, and especially for prevention.
Okay, so I can maybe just add a bit, assuming that, you know, I understood, I caught enough of the question. But yeah, so maybe interesting for the Yugoslav context was that there was this kind of early push, well, maybe not push, but there was an early attempt to advocate for a social, for a public health system which would employ doctors rather than being based on private practices, even before Socialist Yugoslavia was formed. And already at that time, you have this enormous pushback by the physicians associations, which don't actually want to hear about that. And I think that much is quite similar. Then what we see throughout socialist Yugoslavia is that, yes, they are in fact capable of building a different narrative of how health can be organized and show people the benefits of being employed in the public service. And I think the best proof of that was that when we spoke to people who worked both in the Yugoslav health system and then they worked in the Croatian health system, they recall this time of transition at the beginning of the 90s when they were being explained the new model, which is again based on a private practitioner who employs a nurse and provides care to a set number of patients, as opposed to a doctor who is employed in the community center in parallel to the nurse and to the other health workers, is that people were actually shocked. So, they couldn't imagine how this would look. And it was the health workers who essentially were saying, well, guys, we don't want to do this. The only way that they managed to get this part of the reform through is because they scared people. And they told them, well, if you're not going to agree to that, then we cannot guarantee you a job after the transition has begun. And so what happened is that, people say, okay, so we'll sign this kind of contract that makes us private practitioners and we'll take nurses with us. And then in a matter of years, you have a kind of restoration of the old logic that was there, because the doctors understand that, well, yes, there's more money in this for us. So we are that kind of socialist medicine and the public service employment worked pretty nice, but this makes us more money. So it is this kind of shift to the entrepreneurial logic that also Sopel was referring to. And one final point where I think it's quite pronounced is right now, because for a couple of decades at least, you had very low interest among people who studied medicine to go and work in family medicine and to work in primary healthcare. It was not seen as something that you would do if you're a good student or if you're ambitious or anything. It changes at the point when they understand that there's more money in there than there is, for example, if they're working as a specialist doctor in a smaller hospital or something like that. So it's again, this kind of shift of a logic, again, completely, just like nothing has happened over the how many years was it? 45 years of Yugoslavia. So it's...
When we have these discussions, it's not only because we're interested in history and what happened in these places, but because, something about these experiments and the way in which they ended can kind of give us lessons for the future. And so I want to know, what would you guys say is the single most important lesson for the present, that we can take from these experiences to sort of move forward in changing the discussions and maybe changing the left-wing approaches to understanding and imagining healthcare and health and social health? What is it from the GDR and from Yugoslavia and from the Soviet experience that can give us kind of a lesson of moving forward? What is the key pillar, the key lesson?
I can begin if you like. I think maybe to just briefly answer both questions. I think what surprised me a lot when we were doing this research was learning about this polyclinic system, which we didn't get into too much today. I definitely recommend looking at the publication on our website to read more about it, because I think it's very interesting, because it allowed me to sort of contrast my experience with my own, healthcare here, and also my kids' healthcare here, and understanding that there was this model of outpatient care, which was just very efficient. The fact that you could walk in, you could see any number of specialists, any doctor, and not have to worry about dealing with your own patient files. Or if the doctor was sick, there would always be a substitute in the same building. You know, I can't tell you how many times we've gone to the doctor here and then they tell you, oh, the doctor's sick. You're going to have to go to the other end of town to a different private practice somewhere else. But you'll have to take these patient files with you because they won't have your patient files. I mean, it's, you know, it's just this fragmented system here is just very frustrating also for patients, you know, and I can't imagine what it's like for doctors as well. So I think learning about this unitary system that's effective and that even, like I said, under these difficult conditions, economic conditions, was able to create an efficient healthcare system was very surprising for me. I think in terms of taking lessons for the future, I don't know if this is a controversial statement in this group discussion, but I would say, you know, when we look at this history, we have to be careful not to think that we can take individual parts of the socialist healthcare system and implement them to the conditions that we have today. I think that if you really look at the root of socialist healthcare, socialist medicine, it is based on public ownership. It's based on socialist property relations, you know, and I think it means that in all these discussions that we're having today, in progressive movements or in healthcare struggles, we really need to still pose the question of property relations. You know, it's definitely more of a long-term question, a long-term demand and objective. But I think, as I tried to really highlight today, is that, you know, this is the framework that allows you to approach health policy from this socio-economic perspective, and realize what, you know, is much touted today as this health in all policies. You know, you hear it all the time in the EU. They're talking about health in all policies, that, you know, health policy should be integrated into economic policy, into social policies, and so on. But look, if you're serious about realizing that, then you need to have the framework for it. You need to have the economic basis for it, and that is ultimately socialist property relations. So I would say that's our, and still must remain the ambitious objective in the long term if we're serious about creating healthcare systems that are oriented around people instead of profits.
Absolutely. And I think that's essentially the lesson that I reflect most on is quite related to that. So the thing that struck me the most is that essentially it worked. So that's something that both surprised me the most, and it's something that I draw most hope from. So it's very, you know, it's very easy to get gaslighted or something when you talk about socialist healthcare, because people say, well, you know, nice try, but it didn't work. It did work. So, you know, constantly remind ourselves that the things that they did, they worked. So the things that we are talking about today, so the right to health, the primary healthcare system that we have, the health workers' rights inside the health system, all of those things were either implemented or they were at least trying to implement them, and they made a difference. So, you know, when someone comes and says, oh, well, it's not really that, it doesn't make that much of a difference if we're in a socialist society, if we're talking about the socialist healthcare system, or if we're talking about a very well functioning and very well regulated health system in a market economy, it's not true. It makes loads of difference. You know, it makes every difference between the health system that you're going to get, and it makes all the difference in the kind of health outcomes that you're going to get. So it's not the same effect that you're having, and I think that's one of the things that maybe as people who think about health from this kind of left perspective is very important to be quite outspoken about. So, you know, another thing that was the most shocking thing for me was how controversial it was in the health community to talk about socialism. It's essentially not allowed. So it's not something that's done. It's something that's considered to be a very bleak part of health history that shouldn't be ever reapproached again or thought about. And the funny fact is that, you know, the best things that we still have in the healthcare system come from that bleak period of the past. So yeah, that's the most shocking, but also I think the most useful lesson that I got, that it's we really need to talk about those stuff.
Yeah, just to pretty much piggyback off of what Matthew and Anna have said, the socialist project is something you really need. And also it, as Anna said, it worked. It works. So I think that's also been really amazing for me as well, is that the assumption is that some kind of high-tech interventionist healthcare is what people need. And then you really unravel and find out that 99.9% of health is not these things. It's every little thing from, and we haven't really discussed the mental health and stress components that make everything worse. And that comes from this horrible world that we live in, the pressure from job. And if you just look at like very concrete example, you know, the platform workers who are pushed constantly to work more and get those orders in, that risk their lives and their mopeds and bicycles and so on, and constantly getting into car crashes and injuries, and also stress of working insane hours just to make ends meet. So all these things show how, in any kind of, you know, organization of life that puts profit, puts survival at its core, is ultimately doomed, is some place that none of us want to live in, or we're trying to find ways of somehow getting out of it right within it. And then having a system where even just feeling that someone cares for you, not just like your family member, if you have family members or friends. I have never lived anywhere where anyone cared, like a state cared for me. Like, and only like Soviet Union for like when I was a child, you know, it was at the breaking, you know, the perestroika period. And I do remember having doctors come to my house and take care of me always. I never went somewhere. They always came to my house. I remember that. I remember also staying in the hospital when I got food poisoning, you know. But there is a level of care when you know that you are not going to die if you get sick, like I feel now, because my two countries are US and Georgia. They're both absolutely, you know, zero guarantees for sickness. No, I live in fear of getting sick and dying. I live in fear of getting sick and not being able to afford treatment. I live in fear of having to go fund me a surgery, you know, like that's a real fear I have, of also humiliating experience when you have to ask people to donate money so you can survive. I mean, this is the American healthcare, is GoFundMe. And so just the dignity of having dignity, knowing that you are not going to be disposed of when you're old or disabled or, you know, unfit for work for whatever period. And it's a different kind of world to live in that I don't remember ever having. And that's something that I will definitely fight for, and I really want to see.
Magnam cię